Suresh, for your kind introduction, and good evening all. And this evening, I will speak to you on homologous recombination repair pathway and how does an impairment of the homologous recombination repair pathway results in several cancers, and what is the need to do homologous recombination repair pathway testing, and the nuances of these testing that will answer the questions which have been assigned to me by the organizers. So I will briefly speak about what is homologous recombination and then try and answer these questions which have been assigned to me. So we know that our DNA is continuously being damaged by endogenous and exogenous insults. The endogenous insults are in the form of reactive oxygen species, spontaneous deep urination, alkylation, oxidation, the errors of replication. Exogenous insult can come in the form of ionizing and non-ionizing radiations, the genotoxic agents in the food, environmental pollutants and cigarette smoke, etc. And each cell of our body suffers 1,000 to 1,000,000 DNA damages a day, and this needs to be repaired. And these repair pathways are absolutely very efficient and very effective. So there are several pathways which participate in the DNA repair, but of importance to us today are the single strand break repair pathway and double strand break repair pathway today. The single strand breaks are repaired by single strand break repair pathway and base excision repair pathway. These are simple repair processes because we have a complementary strand which is available as a template to fill this gap and bridge the gap. On the other hand, the double stranded breaks are difficult to repair because we do not have a complementary strand. And nevertheless, the repair does occur, and it occurs by a process called homologous recombination. And when the homologous recombination fails, the repair is still carried out by what is called as a non-homologous end join. So let's see what is homologous recombination. In the process of homologous recombination, when there is a break, double-stranded break, a complex which is called mRNA complex of protein is brought in. This complex then brings in more friendly proteins which splint the break so that the strands don't collapse. And it also creates these overhangs. And such 5' to 3' overhangs are created. And then other companion proteins are brought in. These companion proteins finally culminate in bringing in RAD51. The RAD51 is the final effector protein. It is a filamentous protein. It coats the overhangs and then insinuate the sister chromatid where the homologous strand lies. And after invading the homologous strand, then it uses this strand for the repair and carries out a repair which is an exact replica of the original. So the DNA is returned into its pristine state. And this process is very efficient, very effective, and requires about 15 proteins to participate. Of them, BRCA1 and BRCA2 are the most crucial proteins, apart from several other proteins like BRIP1, BARD1, ATM, CDK12, CHEK1, 2, etc. For whatever reason, if this pathway is not functional, if this pathway is ineffective, then the repair happens what we call as a homologous recombination deficiency. Then the repairs occur through what is known as a non-homologous end joining. The non-homologous end joining is a simple process in which the two broken ends are identified by two proteins, a heterodimer of Q70 and Q18. They identify this site of break. They carry out the removal of the overhangs, and they ligate these two ends by using ligase 4 and XRCC4. Now, what happens in this pathway is that we are losing some genetic material. The genetic material has been removed, and the two ends, after removing the genetic material, have been polished, blunted, and tied up with each other. So, but what has happened? There has been a loss of genetic material. The reading frame has altered. And once the reading frame alters, this is something like a mutation. So this process is mutagenic, and hence it is carcinogenic. And this homologous recombination deficiency has been identified to be responsible for several cancers, most significantly breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. And as far as the prostate cancer is concerned, 23% of the prostate cancer are initiated by homologous recombination deficiency. And this alteration is a driver alteration and occurs early. And this is an important point to remember for the purpose of testing, that this is not an evolutionary change, but this is an initiating change. So in summary, there is a loss or dysfunctionality of one of the HR proteins which make the HR pathway ineffective, leading to repair by non-homologous end joining, which is carcinogenic. But that brings us to the question, why is there a loss or dysfunctional HR protein? And this is because of several genomic perturbations, and these genomic perturbations can be in the form of germline alterations, where a mutation is running in the bloodline and has come from one of the gametes, the spermatozoa or the ovum, and this mutation is carried by all the cells of the body. In certain instances, this can be a somatic inactivating mutation in one of the genes coding for these proteins. And in this case, the alterations are seen only in the tumor cells and not in all the cells of the body. And then this protein can also, the genes encoding for these proteins can also be silenced by epigenomics, like promoter methylation of the promoter sequences, which results in no protein, though there is no mutation, and this change is also seen in the tumor cells. So with this knowledge, we will see what are the attributes of a cancer which have germline genetic alterations, and what are the attributes of the cancers which have a somatic genetic alterations. So those cancers which have a germline genetic alteration, they account for about 11.8% of all the metastatic prostate cancers. And the germline HRR mutations are associated with aggressive phenotype, higher stage at diagnosis, and inferior survival. So 1.6 to 3.8% of the prostatic cancers which are low risk have germline mutations. On the other hand, the metastatic prostatic cancer have these germline mutation to the extent of 7.3 to 16.2%. And most of these germline mutations happen in BRCA2, ATM, and CHEK2. They're followed by BRCA1, PALB2, and RAD51D. Now, because these are germline mutation and one expects that these are traveling in the bloodline, but that's truly not the case. So one cannot actually find out those cases who may have germline mutations solely by the family history of prostatic cancer or other related cancers. 46 to 67% of the patients have no family history. And this is important for finding, for determining who shall be tested for germline mutations. And the germline mutations are tested on blood and buccal swabs. And these germline mutations have predictive value. That means they help us in deciding or choosing the therapeutic options. They also are prognostic markers because patients with germline HRR mutations have aggressive phenotypes. And it is also used for finding the predisposed in the kindred of the patient who had prostatic carcinoma. That means for the purpose of family screening. Now, as far as the somatic mutations are concerned, they're seen in 19% of the localized prostate carcinoma and 23% of the metastatic castration-resistant prostate cancer. Just about double the numbers that you see that you see with the germline mutations. So for somatic mutation, we carry out testing the tumor specimen. But remember, when you test the tumor specimen, that will also show up the germline mutations. So when you find a mutation in the tumor tissue, about half of them are actually of germline origin. And this, the physician treating the patient should be aware of. The somatic testing is useful, but because it increases the pool of patients who can receive PARP inhibitors. On the other hand, the germline testing is uninformative for the mutation that has specifically occurred in the tumor. The somatic mutations are useful only as a predictive and prognostic marker, but not for carrying out the family screening. So what are the various HRD tests that we have? So as far as finding the inactive genomic alterations are concerned, we can use a germline test using an NGS panel. And for this, we will need blood or a buccal mucosal swab. For somatic testing, which is again done by NGS, we use the tumor tissues. And remember that they will carry the germline mutations apart from the somatic mutations. It should also be remembered that the testing of tumor tissue, one may not find the big indels, or big indels means big insertions and deletions or large genomic rearrangements, because the processing and preparation of a formalin fixed paraffin embedded section results in breakage of the DNA. And for big indels, one shall carry out the testing on blood using multiplex ligation probe assay to find out the big germline indels, which can then be used for as a predictive marker for use of PARP inhibitor. As far as the promoter methylation is concerned, it is mechanistically significant, but it is of no clinical use, and we don't test it as yet for making any therapeutic decisions. And then there is a surrogate test which is available, which finds the pieces of evidence of a failed homologous recombination repair pathway, where we see the genomic scars of double-stranded breaks. And these can be seen in the form of loss of heterozygosity, telomeric allelic imbalances, and large state transitions. This test is used for as a predictive marker in ovarian cancer. However, it has not been used as a predictive marker in prostate so far. And the last category of tests that one can do are the functional assays. These functional assays are to demonstrate that there is a loss of the function of a DNA repair in presence of a particular mutation. These are used only for the research purposes and in settling what is called as a variant of undetermined significance to figure out whether it is pathogenic or not pathogenic. So in common parlance, when we do a germline or a somatic test, we call them HRR testing. And when we look for this genomic scar using this proprietary test, we call it HRD testing. But this is just a colloquial usage, not on the basis of any scientific data. So why do we test? So we test, number one, because the individual or the patients with homologous recombination deficiency can be treated or selected for treatment with PARP inhibitors in metastatic castration-resistant prostate cancers. And it has been shown that 60 to 80% of homologous recombination deficient patients will demonstrate clinical benefit on use of PARP inhibitor, while those which are homologous recombination proficient, only 6 to 9% of them will exhibit a clinical benefit. And we all know that the PARP inhibitor basically block the PARP, which is a polymerase called poly-ADP ribose polymerase, required for repair of the single strand breaks. Once the single strand break is not repaired, during replication, it is converted into a double-stranded break. And in the setting of a deficient homologous recombination repair pathway, no repair of double-stranded breaks occur. And these double-stranded breaks accumulate to the extent that a sublethal injury becomes a lethal injury, resulting in cell demise.
My apologies, sir. You are just left with 1 minute to conclude your presentation. Okay. Thank you.
So the PARP inhibitor there are two approved PARP inhibitor, olaparib and rucaparib. For olaparib, we need to test the entire HRR set of genes, and for rucaparib, we can just test BRCA1 and BRCA2 in both germline as well as somatic setting. Now, this is also important from the point of view of prevention. Let us say this is an index case of a prostate carcinoma. once he's tested for germline mutation and he's turned out to be positive, let's presume for a BRCA2 mutation, then we will extend this testing to his kindred, the first degree relatives, and it is expected that 50% of them will be positive. So we will find 3 more positive, and this we will do by testing only for this mutation and not for the entire HRR panel. So this is a very cost-effective process and allows us in finding large number of kindred who are mutation carrier and at a risk of suffering prostate cancer and other hereditary breast ovarian cancers. And why is it a very powerful preventive strategy? So if, for example, in a general population, if we do the screening, we will find 1 positive out of 800 individuals. While if we test 100 cases of prostate carcinoma, we will find 12 patients positive with the germline mutations. And if we have 4 family members to be tested, we will test 50 individuals. Of them, 25 will be positive. And to find 25 positive in general population, otherwise, we will need to test 20,000 individuals. While here we test only 50 individuals, that too with a site-specific test, specific for the mutation that we have seen. And these are the instances. So we have to do germline testing for all cases with metastatic disease, locoregional disease, with very high risk disease and high risk disease. Patients who do, or individuals who do not have a prostate cancer, they can also be tested provided they have this family history. And you can find this in the NCCN guideline. And then again, the prostate cancer, patient with the prostate cancers who are intermediate risk, but have intraductal or cribriform histology, or who had a personal history of a pancreatic, colorectal, gastric cancer, melanoma, etc., are also the candidate for germline testing. So the choice of test for predictive use, it is the somatic testing and tissue biopsy, and especially the latest biopsy is preferred. However, as I said in the beginning, that these alterations are early and archived tissue is as good as a fresh tissue in case the fresh tissue is not available. The bone biopsy must be avoided. If tissue is not available, try liquid biopsy. If the liquid biopsy fails and you are unable to extract enough DNA, at least do germline testing if it has not been done earlier. You will still find about half the cases who can be treated with PARP inhibitors. And one question you must always ask the lab, if you find a low variant abundance, you find some mutation which is happening at 7%, 8%, 9%, shall you use this information for therapy selection? So there are passing references that any mutation or alteration that has been seen at less than 10% should not be used for therapy selection because it is likely to be a false positive, an artifact of PCR or sequencing. And because tumor testing cannot identify large genomic rearrangement, it is my suggestion to all oncologists that they must always combine the somatic testing with MLPA for BRCA genes on blood, because 10% of BRCA2 genomic pathologic genomic alterations are in the form of big indels or large genomic rearrangement. And the last question is, what shall you test? Shall you test for all 15 HRR genes or just the BRCA2, BRCA1 and ATM? In United States, the recommendation is to test for all the genes. In United Kingdom, it is for BRCA1 and BRCA2 only. In Canada, it is for BRCA and ATM, while in India, we generally follow what happens in United States. And in case, as I said earlier, tissue biopsy is not useful. You can use liquid biopsy, tissue is not available, or it is a bone biopsy which is not yielding result. You can use liquid biopsy. Sensitivity of 60% to about 90% has been seen. It's a good alternative. And if this also fails, then at least do the germline testing. And as far as the germline testing is concerned, it is primarily for preventive use, but it can also be used for as a predictive marker. When everything else fails, it is simple to handle, results are more reliable, and it will identify big indels. And as I said earlier, genomic scars is not used in prostate cancer. And what is the time when you shall test? Well, you can test at the time of diagnosis, you can test at the time when the first metastasis happened, but I think the most ideal time will be when the first line of treatment in metastatic prostate cancer has failed, and one has the option of using PARP inhibitors. So I will give this a go. And as far as the germline HRR testing is concerned, there's some recommendation. Usually 2 counseling should be offered 2 to 4 weeks apart. Blood should be taken at the second session, and result should be given 3 weeks later with post-test counseling, and positive cases should be encouraged to inform the relatives at risk and motivate them to obtain mutation testing. We generally report the germline testing in pathogenic, likely pathogenic, variant of undetermined significance, etc. The pathogenic and likely pathogenic should also only be used for family screening and for use as a predictive marker. A good and a smart lab shall keep an account of the variant of undetermined significance and periodically review it, let's say at each 6 months. And if there is any change of status, this should be informed to the patient and his physician. And for somatic testing, the reporting is done as a tier 1, which is of a strong clinical significance. That means you can use it for therapeutic intervention. Likewise, you can also use the tier 2 for therapeutic intervention, which is of potential clinical significance, but the variants of unknown clinical significance and benign or likely benign variants are not used as a predictive markers. So with that, I will conclude. I have overshot the time, I know, but HRD testing is essential in prostate cancer from both from the point of view of making therapeutic decisions, because PARP inhibitors have shown a median PFS benefit of about 4 months, as well as an OS benefit of about 4.5 months, despite large crossovers from the other arm. And therefore, PARP inhibitors are useful. And more significantly, I think you can find many healthy mutation carriers who can be given risk reduction strategies and a normal lifespan. Thank you so much.
Thank you, sir, for this wonderful talk. I think your talk has shown us that clarity and brevity comes from extensive knowledge. And though I'm sure there will be a few questions to your talk, unfortunately, due to lack of time, we'll proceed to the next talk. But I would like to request you to stay on to the panel discussion. Maybe a few questions can be taken during the panel discussion.